during the World Glaucoma Congress. First of all, I would like to warmly thank my colleagues from the Program Planning Committee for organizing this wonderful session and for including me with this lecture on unmet needs in surgical therapy. These are my financial disclosures. And let's start with the aims of glaucoma treatment, which according to the guidelines is to maintain the patient's visual function and related quality of life at a sustainable cost. So you see that visual function preservation is key. And how can we do that? Well, these landmark trials have clearly shown that lowering intraocular pressure does help us to maintain the patient's visual function. And how effective is trabeculectomy to lower intraocular pressure? Well, here you see 3 different studies that show the long-term results after glaucoma surgery, after trabeculectomy more specifically. And you see that they very, very consistently show that trabeculectomy lowers the pressure to the lower teens. So indeed, trabeculectomy is still the gold standard because it is the most efficacious procedure, achieving low target pressures near 12 millimeters of mercury. We have long-term data available, and most of the patients were drop-free. However, here's the backside of the medal. Complications do occur after trabeculectomy. And you see here from the TVT study that the incidence is not very low. Almost 40% of patients had early or late postoperative complications. And even a reduction in visual acuity. You see that more than 40% of patients with either early, with or without complications, actually had a decrease in their visual acuity of at least 2 Snellen lines. And that is really what keeps us glaucoma surgeons awake at night. How I have to make a side note here. This is a more recent publication about trabeculectomy outcomes, in which you see that with modern trabeculectomy techniques, the incidence of postoperative complications has gone down. So what is the problem then? Well, actually, after trabeculectomy, postoperative manipulations and interventions are needed to ensure these nice long-term outcomes, such as subconjunctival injections, bleb needlings, suture manipulations, resuturing, and even cataract surgery. And that is true not only with the older studies, but still confirmed with the more recent studies using the more recent trabeculectomy techniques. So this is still a reality. After trabeculectomy, you do need good postoperative care to get the results as expected. So what are we dreaming of as glaucoma surgeons? Well, Professor Kaur called it the 10-10-10 procedure, meaning a procedure that would take 10 minutes, would bring the pressure down to 10 millimeters of mercury, and that would last for at least 10 years. This is really why in the past decades, a lot of efforts have been done to invent newer surgical techniques, targeting different routes, subconjunctival space, Schlemm's canal, suprachoroidal space, and taking either an up external or an up internal approach. And again, I want to make a side note that according to the EGS guidelines, only up internal non-bleb forming procedures can really be defined as minimally invasive glaucoma surgeries. And based on this, actually a recent publication from my colleagues, Dr. Sunaric and Professor Braun, have proposed this classification, where on the one hand, you have the truly minimally invasive glaucoma surgeries, the MIGS, and on the other hand, you have the device-enhanced subconjunctival glaucoma surgeries, the classical ones, and the more recent ones. But let's start with the MIGS then. What evidence do we have around their efficacy, safety, and cost? Starting with efficacy, from the studies that we have available, we know that the pressure-lowering efficacy is not as impressive as with trabeculectomy. This is a systematic literature review on the MIGS outcomes. And their conclusion was that indeed trabeculectomy lowers the pressure to 11 to 30 millimeters of mercury, whereas with MIGS, higher postoperative IOP levels are observed. And therefore, they conclude that MIGS are best suited for patients with mild to moderate disease in which lower target IOPs are not necessary, or to reduce the topical hypotensive load. Well, there again, I want to make a side note, because the EGS guidelines do confirm that MIGS provide modest IOP lowering, but regarding the decrease in medication burden, they state that decreasing medication burden is not in line with the traditional aim of glaucoma surgery. And regarding phaco-MIGS, they state that it is difficult to separate IOP lowering effect of MIGS from that of phaco alone. How about safety of MIGS? Well, the CyPass story has clearly alerted us that even minimally invasive glaucoma surgery does have safety or can have safety issues. So again, the systematic literature review said or alerts us around the potential risks and adverse events of minimally invasive glaucoma surgeries. What about cost? And again, I want to point your attention once more to the definition of the aim of glaucoma treatment in the EGS guidelines, which also mentions that we have to maintain visual function, but at a sustainable cost. Again, the systematic literature review tells us that there is actually only limited evidence available on cost effectiveness of MIGS. So, as you can sense by now, MIGS are associated with some problems, as again stated in the recent publication from Dr. Sunaric and Professor Braun. To start with, there is a lack of a clear definition of MIGS, but they have provided or proposed a solution to that. There is a variability in the quality of reported data, and that goes together really with the fact that most of these studies were done in a sponsored way, and therefore there was a conflict of interest of the authors. There is an uncertainty around indications, and also uncertainty around cost effectiveness. What about the device-enhanced subconjunctival glaucoma surgeries? This is again a recent publication comparing the XEN and the microshunt PreserFlow. And this table summarizes the IOP lowering results. And you see after 2 years that microshunt resulted in pressures of 12.1 millimeters of mercury on average, and with XEN that was 13.8 millimeters of mercury. I want to point your attention also to this table that shows that postoperative bleb management is also needed after these procedures. They are bleb-forming procedures. In XEN, 24% of patients needed postoperative bleb management, and in microshunt, that was 10%. How about safety then? The systematic literature review points out that for procedures in which bleb management is frequent practice, many studies do not classify these as an adverse event. And thus the true impact of bleb management remains unclear. Moreover, these postoperative manipulations and interventions can have an impact on time and outpatient resources or costs. So, all in all, extraordinary claims require extraordinary evidence. And as we all know, sometimes extraordinary claims are made around the newer surgical techniques. And that is why I want to cite the EGS guidelines once more, because they say that newer surgical techniques, insufficient evidence for efficacy, safety, cost effectiveness compared to trabeculectomy is available. I thank you for your attention.